There is a presentation, I have understand.
Yes, there is a presentation um,
About the
about.
post-operative compression, I think. It was planned to be, not? By Darshan?
Yes, Khaled, can you show the presentation?
Yes, that's the one, Dr. Darshan.
Thank you.
Yeah.
So this is a wonderful case that we are all getting to experience at Dr. Ravul Jindal's clinic. And as they say, you don't make a good sailor by only sailing smooth seas. So this is a wonderful example for everyone where you get not just the easy stent deployment and everything, which maybe a lot of trained vascular surgeons can do, but such cases which bring out more discussions, more options, and more therapy uh, variations that each and every patient show. Now, it's been long established that elastic compression stockings are recommended, of course, after DVT and to prevent post-traumatic syndrome. But after acute DVT, stockings, how long should the stockings be worn is always a matter of discrepancy between the global leaders, where the prescription range starts from maybe some people say wear it for 2 months or 3 months, some people say lifelong, depending, of course, also on the patient condition. However, there is a certain study called Octavia study, which, from the point of view of preventing PTS, post-thrombotic syndrome, after DVT, it shares a light on what could an ideal duration be. Next slide. Thank you. So this Octavia study was designed to assess whether stopping compression therapy at 12 months would give any different results compared to at 24 months, right? So a randomized controlled trial was designed, and total patients of 518 were enrolled, out of which in group one, where we stop compression therapy after 12 months, and then we have group two who have for 24 months and follow up at 24 months. Next slide. So the primary outcome was PTS incidence was noted at the end of 24 months after DVT diagnosis. And from the results, we see that the stop group had incidence of 51 post-thrombotic syndromes, whereas the continue group or the go group had only 34, which showed in this one particular study that 60% higher risk for PTS in stop ECS group. So at least with this study, we have a little bit of better idea about how we can proceed and give compression therapy for a longer time. Also to be noted is that a higher compliance rate was shown in the continue ECS group, which is the compression stockings group. 85% wore compression stockings for 6 to 7 days a week. As we all know, compression therapy usually fails because of the compliance from the patient. It may be sometimes difficult to wear and remove, or it may be uncomfortable, or some such reason. So, what we recommend and what we at Sigvaris try to do is always improve compliance from the patients by using all our efforts in right from beginning of the process of developing the stocking itself until the end. Even our end channel supply chain also makes sure that the patient have been measured properly, has been shown how to take care of the stocking, how to wear and remove, etc. Next slide. So there are three major points. If we look at the full type stockings, three major points where we take measurements from. One is just about the ankle, the thinnest point. Second, calf measurement we take from the head of fibula or two fingers with below the knee bend. And the third, at the groin area, which is the full thigh stockings measurement, which is just below the buttock crease. Okay. And the length also for because different patients from different parts of the world have different heights, different lengths of the legs. So it is very, very important for us that we uh, give the patient the correct size in order to make it much more comfortable for them. Next slide. Once we take the measurement, it is important for the company, for the product to also have adequate number of sizes so the fit becomes more custom made like feel. And this is why people, uh, as you know, I'm also a distributor for Sigvaris since 25 years. And our customers love Sigvaris stockings because the sizing availability is so wide. Now, in this patient, before we started the case, I had taken the measurement and large, long was the size that's decided. And maybe because of shorter time, maybe I won't be able to give a live demo again on the patient. But it is vital that we do this exercise, take the time to measure the stockings correctly, make it fit properly with the use of hand gloves or any of the amazing donning devices we have, for example, Doff and Donner, and therefore improve patient compliance. Next slide. And to thank you for the time given during this MOH Connect for me. Sigvaris Group is dedicated to helping people feel the best every day. Over to you, Dr. Erika Mendoza.
Thank you so much for your presentation. And we have decided to go back to the operation theater to hear what Ravul has sorted out. And just before I finish talking, I want to thank
Can you see
team
this?
of Ravul and everybody participating in Sigvaris for the occasion, because this was really interesting. So Ravul, the mic is yours. Tell
Yeah,
us
thank you. So
what
what you can see out here is, so what we did it with a balloon, bigger balloon, 10 into 80, and you can see now the deep femoral vein flow has increased and the profunda flow has decreased. You can see this as
perfect.
compared to the first one. So there are Seneca there. I leave it alone there. Go up, please, a little bit. And this is a good sign, and very good sign. And there is no contrast holding, which is also a very, very good sign for me, because this was the main obstruction. And now you can see there is very little flow into the profunda and good flow into the deep vein, which is we wanted. Up, please. So I'm very happy with this. Push towards yourself. So now this is my main critical area, which will make me decision making. Should we do the stent or not? And as you can see, both the profunda and the femoral, they are joining. So now I can place the stent, bring it down up to that point of lesser trochanter or into the deeper vein, a femoral vein, and which can give us hopefully a good inflow and good results. So please, if the all panel agree, I'll just like to dilate it here once more with a bigger balloon, and let's hope we get it. Stop, please. And let's see. 14 we have. Yeah. So what do you say? Should we do it? Because now we are able to improve the inflow after doing the ballooning of the whole of the femoral vein. So now there is a good inflow from profunda and the femoral. So now we don't have to land the stent in profunda, which I was very reluctant. And so now we can land the stent here into this. So please make suggestions, and what do you think about
Do
it?
you like to say your opinion, Erika?
I am the least one to do so, but it looks logical what you say.
Doing
Yeah. Well,
different.
from my very limited experience, I like to have the flow in the groin to be much brisker and more amount of flow. I think maybe the reason because he's injecting the dye from the popliteal vein. But what I usually do is put a catheter into the upper femoral vein and inject from there. So there's no flow go to profunda, because the information I want to know is from the groin to the iliac. Is there is any obstacle in this area? And I wouldn't get this information if I inject from the popliteal vein, because by the time it reaches the groin, it's nothing there. The way he dilated was excellent. All the synechia was passed. And now I think is the reason he doesn't see a flow because it is diluted by the time it reaches the groin. If it was me with this image, I will be reluctant still to put the stent in and maybe anticoagulate and see how it was. But this is from my limited experience, and this is probably
Sure.
what I usually do.
Can I have 6 French guiding with the Y connector? Yeah, absolutely. That's a very valid point, and that's why I was very reluctant. So I'm going to dilate this, and
Yeah.
so that's the plan.
Yeah.
So I'm
Sometime
going
I
to.
do another trick, which I call it ballonogram, but no other people have done it, which I inflate the balloon at 12 millimeter, put it in IVC, and pull it down gently. And this way, as if I'm doing a roadmap with the balloon, that's why I call it ballonogram. If it goes from SFA to the groin without really any tough lesion, usually stent will be okay. This is one of the other tricks that I use.
No, sure. My only limitation to stenting is an inflow. So,
Yeah,
so I'm going to do this and see how my inflow goes up, because now we are dilating with the 14 there, with a good
yeah,
inflow from the profunda and that, and then
yeah,
I'm going to take a catheter because now I know from popliteal to the lesser trochanter my flows are good. So I'm going
yeah,
to put in the catheters there,
yeah,
and then once we have done this, and take another
yeah,
venograms there, and
yeah,
then we will do the IVUS
yeah,
and see where how the things are, how the flows is, and now you can see very tight lesions here, which we have opened up, and go up, please, Piyush. That's it.
Well, I have a question
Yeah.
because time is running out
Yeah.
and we will not be able, unfortunately, to see the end of the procedure.
Yeah, I can send you the photographs later on.
Yes, please, could you? Because so we could make it for everybody can have a look at this MOH
Yes.
afterwards, and we
Yes.
would
Yes.
add the steps until the final results. I mean, if you could
Yes.
make
Yes. So what I
the
can do, because
IVUS,
I can take some time here because it's a long case.
yes,
So we'll just take a venogram and then we can stop the MOH, and then I can continue to make a decision. Just wait for 2 minutes, and
we have still some time. I just wanted to plan that we can offer the wonderful
yeah,
results you will have.
and so that we are able to open it up.
Yes.
Yeah. Deflate, please.
I mean, I would stay here for 3 hours if necessary,
No,
but I
no,
think
no,
the
no,
whole
no, 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 please not. Okay.
Raul had shown us the elegancy and experience of doing such difficult cases. These cases are nightmare for us. And my usual time is something between 4 or 5 hours. He has done it beautifully, and we're still less than 1 hour. So it's fantastic. It's just we have the broadcast time is the problem.
No, 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 please. So we have just done the ballooning now. So I'm just going to
Okay.
withdraw this balloon and out, and we are going to take one angiogram now, and at the common femoral, which is the main area. No, no,
Yeah.
that's it.
and one of my take-home messages is this looks easy but isn't. If you
Yes.
need
Absolutely.
something like this for a patient, make sure that in your environment, in your surroundings, you have somebody doing this very experiencedly and send
Yeah.
the patients there, because this is not try and error. This is really mastery. And
Yeah.
I think in every country you have some people doing like this experienced ways, and it is not a shame to send difficult cases to very experienced persons,
Yeah.
just to give them the
Totally agree.
opportunity to have these results.
Yeah.
So I'm going to take a Y connector now and my 6 French catheter, and it is nicely moving, which is good. And I'm just going to keep it lightly lower than this, so that I can get the inflow from the femoral vein and the profunda.
Yeah.
And I'm going to
Now, this image will be totally different from the image we had before because here you have a flow starting at the femoral vein. You will see collateral to the other side disappearing, which is a very good sign. And you will see the flow with the disappearance of synecdoche to the IVC.
so this is the situation where we are.
Yeah.
Okay. So down, can you come down a little bit? That's it. Please. That's it. So I'm going to see the inflow from the bottom because that is the inflow which is going to keep the stents patent.
Yeah.
So as such, inflow is not bad. So now we all can decide what is to be done.
And the stent would be down to the common femoral vein.
No, the stent will be down actually up to the lesser trochanter. So it will be coming down. We are going to put in an 18 at the top,
Yes.
and then depending upon the length, what we have available, and 14 mm coming up down into the SFV. So, we are going to measure the length up to this point with a pictal marker, and then we are going to make a decision on the length what we have available and what stents to use. But normally it will be 18 at the top. We are going to use most probably an obliquus or whatever we have available, and then we may have to put in either the 16 in between or 14. So maybe 2 or 3 stents, what we are looking at, if we have to put
Yeah.
in into this.
Yeah.
So it's a long occlusion, and long stents has to be put in. So that's what we are looking at.
Okay. And the leg bending is not influenced by the stent.
No.
No.
So that has been shown. There was a study published here that if you have transinguinal stents, putting in those stents, actually talking, it does not make a huge difference.
Okay.
So yeah. So that's the plan, Erika. So I'm
If you,
just
I don't,
thinking.
yeah.
So I'm just thinking because there is a good flow from SFV, and so we should go ahead and put in the stents there, and um, bring it up to the profunda here, and hopefully that should help us in getting this patient some relief in terms of the PTS symptoms. So otherwise, other option is we just leave him alone now and see how his symptoms are, because we have done a lot of ballooning. We see a lot of patients whom we have done the ballooning just like this, because we have opened up a lot of channels, and a lot of these patients, they improve. Please go up, please.
Yeah.
But now
And
you brought the stent up, yes, correct?
no, this is pictal marker.
Yes.
Up, please. And so what I'm doing is I'm measuring the stent size now. So down.
Okay.
So from the IVC, it is coming down. So this is 20 centimeter here, down, please, to the head of the femur, like a pubic symphysis. And then another ones I will go up somewhere here. So this will be another 3, 3, 6, 3, 9, 10. So around 30 centimeter area I need to cover.
Yes.
So I will be, now I know that I will require somewhere around 30 to 33 centimeter of area of the stents. And so I will choose my stents sort of accordingly,
You
depending
fuse them
upon that.
outside?
Sorry?
You fuse them outside or inside? You fuse them previously or you introduce them step by step?
No.
Step by step.
Step by step.
Okay. Yes.
So yeah. So this is one. Second is we can also do an IVUS and see and what sort of vein it is. But because my decision is here. My main decision is here in the common femoral vein, which is making a difference. I'm not worried about the iliac vein at all, because that stents will open up. Ultrasound, please.
So if I may ask you a favor, if IVUS is not extremely necessary, I would love to see the first stent just in position.
Yeah. So
If
that's
we-
the, yeah.
If we still have
that,
this time.
yeah. So that's the vein we are looking at. See, it is artery here, and we can see the vein is very diseased here. So you have to put in a stent across this. You have to see. So for me, making a decision, should we stent it or not, will depend upon still further IVC study, IVUS study. And so now where I'm looking here, if you look into it, artery is good, but vein here looks nice. It's not, doesn't look bad. And my guide wire you can see. So I may be able to land my stents here, this area. So this area looks very nice for me to land here. You can see down, and this is the profunda. So the only thing is I have to jail the profunda here, because I cannot land here in the common femoral vein, because if I put in the lower end of the stent in the common femoral vein, it will not flow. So this is definite. So either I make a conscious decision that I don't do anything and leave the patient alone, or I make a conscious decision that I need to bring the stent here in this part of the vein. So because if you see in the transverse section, so this is really bad vein here, but if you look into this area, the vein is not bad. So that bad, I can see the artery, and it's not, of course there is seneca inside, but it's not that bad. So here it will be a good area to land. So if I have to land, I will land here. So we can do the IVUS and then decide, and that should be the thing. Okay, can I have the catheter, please? Quick, कोई भी catheter दे. लो, उसके पीछे वाला उतार दे. Oh, that's a fix. 18 की वायर. नहीं, IVUS start करना please. अभी नहीं, मतलब like okay. So I'm just going to take up, push up please. I'm going to change the wire. Now the Boston, up please. Okay, so I'm taking the stiff wire out, 18 wire please. So we are changing it with an 18 gauge wire, 0.18 wire, and I'm just going to show you how to prepare the IVUS once. So we are going to put in this 18 gauge wire inside, so which we have here. So we have the 18 gauge wire inside here, and wire मत पकड़ो, पीछे से गैस कोई निकल जाएगी. Okay. So now can you have the focus camera here please? On ये attached है ना? नहीं, वहाँ पे attached है? हाँ? Okay. Okay. So we got this IVUS catheter. Can we have the focus? And we are going to take it out from here, and it's a very fragile ultrasound catheter, which is there at the absolutely at the tip. You can see a very 2 millimeter small ultrasound which rotates around. So we are going to prepare it. I'm going to fix it up first of all. So this is how you fix it up, and you go inside, and you fix it up very nicely out there, and then you need to flush. Now, flushing is very important aspect of this, and which is because if you have an air inside, then you cannot see anything. So we attach the catheters. Saline it? Okay. Okay. So I'm going to use a three-way connection and use the flush the. If you look into this, if you look into this, we are going to do the flushing, and you can see the saline coming out. So we are going to flush it at least 2 or 3 times to remove the air out of that. So you can see the whole air is getting removed, and it is a rapid exchange system. So the wire will come from the side of it, by which we will know. So now our IVUS system is ready, and we are going to put it inside now.
It's astonishing how little devices are developed.
Yeah,
It
and
is
so now our wire, and gently we have to be very, very gentle, because it is, can you see, it is just a small tiddly bitly ultrasound, and
yes.
very, very, it's like a coronary stents which we put in, and so you have to be very, very gentle and inside. And so this is how we have taken the IVUS inside now. And Piyush, can you just bring it here? Okay, machine, here please, down, bring it 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 down, that's it. Okay, so now you can see further forward. So yeah, that's it, here. So here we have, so this black color thing which you can see on your C arms is the ultrasound, IVUS ultrasound. And can I have the 4 screens? Can I have the IVUS also on? And
Your team is great. I mean, this is a technical, wonderful thing to see.
yeah, so we got the IVUS now, we got a C arm, and we got 2 pictures. Ultrasound we don't need. So now we have got this, so we, by which C arm we know where exactly we are. And now we are going to start the IVUS from here. Ideally, we'll start from the IVC, but I'm just going to give it a relay. Please, can you just make it sure it's okay, it's working well? Can you just put it on? Yeah, so it is working well. Okay, stop please. Okay, so I'm going to take the, now it is on the IVUS, absolutely to the IVC. So take the machine up, please. Go, go, go. Mani, please. Mani, पीछे देख रहा था? Please, okay. Okay, go up, go up, guys. Go up, towards yourself, and make, you can make the machine straight if you want, no problem. Okay, go up, go up. So you can see I'm at L3 level. So I'm going to be at L2 level here, and L1, L2. So maybe the renal veins and arteries here. Okay. Huh? क्या करना है? किसमें? मतलब? ये अपने में करता हूँ, वो अलग सिस्टम है, फुल बैक, वो अलग से लगानी पड़ेगी, ट्रे लगानी पड़ेगी ना, वो जरूरत नहीं है ना.
IVUS is becoming very important rule. It's an essential if we're going to put a stent. You cannot put the venous stent without an IVUS. I think is the
Okay.
overall agreement.
So okay, guys, start.
Yeah.
Just a minute. So we just need to enter the name of the patient, which is important. They forgot to make it ready, the machine. Okay. Vessels change, Piyush. Vein, no, vein, Piyush. Down, vein. Yeah. Click vein, imaging, click imaging. Yeah. Okay. Fine. So saline, air careful, put in a saline, more, flush. Okay, that's fine. So we are still not very clear about it. No, it's not very clear. Why? It's still a lot of air is coming inside. No, I think this. Just a minute. Settings are. Just go to the case setting. Below, absolutely below. Yeah, below. Yeah, case setting. Yeah, put in depth as 16, 18. Yeah, that's fine. And brightness to 8. 7 is good. Okay, that's fine. Okay. And de-speckle pullback speed, recording setting. Okay, fine. Now let's see again. Flush and let's stop. So fish depth is more. We need to decrease the depth a bit. 16 will be fine. Yeah. So now here we can see I'm withdrawing locally slowly, and you can see the how it goes, and you should be able to clearly see the right common iliac vein coming in, a big black color thing.
You are going up. Yes, are you going up with the device?
No, it's not very clearly seen. I'm not very happy with it. I'm just trying to see why the machine is not working properly. So that's what I'm trying to sort it out. There is some issue with the thing. It's not working well. Why? I am just trying to figure it out. It should be very clearly seen.
Because the ultrasound transducer is very, very thin in Boston Scientific IVUS
Yeah.
machine.
Yes.
Sometimes it can very easily damage, and usually we face some situation like this that we have to change the catheter because it's just a minute amount of transducer can be
Yeah.
very easily damaged. Yeah,
But we just took absolutely new catheter, and
yeah,
so there should not be any issue because I'm still not able to see it properly, and
yeah.
I'm just trying to see why we are not able to see it properly, and we should just do this settings again on the optic arc on the vein, change the vein to the iliac, yeah, okay, and then change the settings again, case setting, and despeckle high, करना default, okay, depth, brightness, grid on off, ठीक है, okay, just try this.
For those not used with IVUS, it looks like you are in tissue. You are not in a vein.
Yeah. So I'm really sorry. I don't know why this machine is not working. It should be very clearly seen. Now here we can start seeing the thing now. Okay, fish. Okay now. Depth is okay. So इसका ना वो करना केस सेटिंग्स में जाना प्लीज सॉरी केस सेटिंग नीचे इसकी ना ब्राइटनेस कम करना 5 करना 6 5 4 ठीक है ओके एंड so okay, so now let's see if we can start doing it again. Flash me. So I am into the IVC now on the C arm, and I should be able to see the common iliac vein, the right, coming in, which I am not able to see here, maybe. So now I'm not sure, sorry. And
You are doing the IVUS to decide something. What were you looking at?
I'm looking at a lot of things, but the imaging is not very. I
I
don't
know,
know
I understand.
why the imaging is not clear. And what I was looking for is how is the iliac veins and how is the common femoral vein and the landing zone. That's my
Yeah.
main area. My
Yeah.
problem is
Yeah.
not the iliac veins. My problem is the landing zone. लेके आना, नीचे
Yeah.
लेके आना,
Yeah.
please. So my problem is the inflow. Outflow is good. So in any vessel to run, it's an iliac vein or artery, anything. Inflow and outflow has to be the main thing. And so we have crossed the wire. We've done the ballooning. So I'm in the iliac vein now, external iliac vein. And now I'm going down. I can see, but I should be able to see it very nicely, which I'm not able to see it in here. So here I am going into the iliac crest, here into the common femoral vein, and here I should be seeing the profunda entering into the common femoral vein here,
Yeah.
which I am not able to see. And because I can see Seneca here in between, little bit white things, but it, it's not very nice picture. So
Yeah.
this is the area you can see the two black spots. So
Yeah.
on the side, so this is the area where the profunda is entering into the common femoral vein, but I'm not
Yeah.
able to see the picture clearly, really. So I'm really sorry.
Yeah.
I don't know why this machine is not working, and
Excellent.
so I'm withdrawing this catheter because it's not very helpful to me.
Yeah. I think
So
I think for sure we will keep the recording of such a nice case because you cannot really rush any venous stenting case, and we can have a take-home message, and then we can add the recording
हाँ,
to the live transmission at
चलो मैं
later. What do you think, Erika?
Yes, I
yeah
think
yeah
we shouldn't put the patient or Ravul in any hurry.
Yeah. Yeah. Exactly.
Already, without seeing the stenting and without seeing the end, it has been a gorgeous case of learning for us.
Absolutely. Absolutely. It's a beauty.
catheter देना
And
So
thank you,
if
Ravul,
if
for
we
being so kind and having shown us everything. And
No, no, sure. Because I'm going to take another angiogram, and if there is a
yeah.
good inflow, then I'm only going to stent. Otherwise, I'm going to leave it alone. So that's
Okay.
the plan.
Okay.
So that's the plan. So, so should I hand over the mic to Darshan for if he wants to speak on compression something?
Closing.
Is done already? You're done already, finished? Okay. So, so Erika, should we close it up?
excuse me.
I said, should we close it up from your side?
We are just
What's the plan?
discussing. We can stop live.
No, no, we can. We are okay. Whatever.
Yes, but we can go on recording.
Yeah, yeah.
So maybe if we can take a nice home message of this case from Erika Mendoza and from Raul, and then we can stop the live, but keep recording, and then we can add it to the live. So when people see it live recorded, then they will see the full version. What do you think, Erika?
I'm very happy if that is possible. And my very important point is here in Germany, I've never seen these cases of post-thrombotic syndromes with this large affection of veins. And
Yeah,
I would encourage all around the world the early diagnosis of thrombosis and the possibility. I mean, it is also a cost question because you can't put people on long-lasting anticoagulation if
yeah,
it is not reimbursed. So we should look for the health problems, and this is a real problematic health problem that people
yeah,
comes up with these impressive post-thrombotic syndromes. So just one appellation to healthcare instances to give for free anticoagulation therapy to these people, avoiding these stages of problems, because lots of people aren't able to approach a doctor like Ravul, and they will have really bad quality of life due to the post-thrombotic syndrome. This
yeah.
is my take-home message.
Excellent. And my dearest Raul, it's a fantastic case, and we like to have a take-home message to all vascular surgeons seeing you doing this procedure?
No, thank you. And you see, my take-home message will be, I think, one or two very simple things. One is early detection of deep venous thrombosis, which Erika mentioned, which is very, very important. And before that is the prevention of deep venous thrombosis is much more important than even an early detection. Because if we are cautious and we know what are the risk factors for deep venous thrombosis, we should be much more careful. Major surgeries, cancer surgeries, difficult deliveries, postpartum, trauma, post fractures, long, stay on the bed, severe viral illnesses. So all these things, they can cause you deep venous thrombosis. You have to be very, very careful, and early presentation and early anticoagulation is a really very, we have so many patients that if you treat them early with an anticoagulation, so the chances of those patients developing a post-traumatic syndrome after 5 to 10, 12 years is very, very little. And nowadays, we do a lot of deep venous intervention. So if you are young, if you're fit, and if you have a massive clot, and you don't have any risk of bleeding, then we are using devices like an angiojet, penumbra flash, and NARI devices in our setup routinely, and we are able to take out all the clots within 14 days of the presentation. And you can't imagine when you see this patient after 3 months, it's so difficult to identify which leg the patient had a DVT. And we have got a follow-ups of such patients at 8 years, 10 years, and they are without anticoagulation, of course, depending upon the history, whether they beat it or not. And the results are amazing because I think you are able to save the valvular functions of the deep veins, and so you don't develop all these bad complications of post-thrombotic syndrome. And I think with the development of newer oral anticoagulants, the chances we are going to see this post-thrombotic syndrome is much lesser now, because with warfarin, we always used to have a difficult to maintain the INR. So I think early treatment, proper anticoagulation, proper compression is the key to the management of these patients.
Thank you so much. I'm sorry, I am told that we can't record if we close the webinar.
No,
So
no problem, no problem.
my ask to you is, could you make like screenshots and send them afterwards?
Yeah.
Yes?
Absolutely.
So
Yeah.
you will record everything for us because we can't go on recording. Yes?
No, sure. So I'm
Okay.
going to record, and I'm seeing the inflow and the last angio maybe down, please. And if it's not good, I'm closing it up.
Okay.
But I will take the screenshot and send it to you.
And you will send everything to us. So thank you very much to everybody, the patient, the team, and Sigvaris, and Mohamed, Omar, and especially to you, Ravul. Gorgeous as always. And I think we will quit now the online session.
Sure.
Thank you.
Thank you.
To
Thank you,
everybody.
Erika.
Thank you. Thank you so much.
Thank you very much for being there today with us. Thanks especially to the expert doctors that had such a lively debate, and we are very thankful for Dr. Ravul Jindal to give this case, and such a amazing experience that you shared with us, with all the listeners. I'm sure it is not a very easy case, or not something that can be done for a first timer for sure. That was great, a great case, great discussion. So thank you very much. And for the rest of everyone, I ask you, you can to follow up with this case and what happens. Is the inflow good or not? Are they doing stenting or not? Go to MOH website, Sigvaris website, and sign up for the newsletter, and check in a week, a couple of weeks maybe, we upload the video with the rest of the recording and the final presentation. Until then, I bid you all goodbye. Thank you.
Thanks a lot.
And stay healthy, stay safe. See you next time. Looking forward. Thank you. Bye.
Hey, bye-bye.
Guys, make a decision.